Dr. Kotrashetti is a highly experienced oral and maxillofacial surgeon with over 23 years of expertise in facial trauma, dentofacial deformity correction, cleft lip and palate surgery, and implant dentistry. He is a professor in the Department of Oral and Maxillofacial Surgery at KLE Institute of Dental Sciences, Belagavi, and serves as a consultant for KLE Smile Train, focusing on cleft and craniofacial surgery. Dr. Kotrashetti's expertise in complex maxillofacial procedures has made him a sought-after speaker and mentor in the field. His dedication to advancing surgical techniques in facial deformity correction and implantology has significantly impacted clinical practice and patient care. We welcome Dr. Kotrashetti to discuss about the management of nerve injuries in general dental practice.
Hello everybody, my name is Dr. Kotrashetti. I'm an oral and maxillofacial surgery. Today we'll be discussing the topic on nerve injury and its management in dentistry. Here I work at the KLE Vishwanath Katti Institute of Dental Sciences in a city in Belgaum, Karnataka, and I also work for the University Hospital of the KLE Academy of Higher Education. Today, in this topic of management of nerve injuries in dentistry, we'll try to understand this subject in the following um, subtitles, that is, to get the knowledge about nerve injuries, how do we prevent it, the identification of nerve injury, and its management. To start with, let us try to understand the human nervous system. The human nervous system is divided into central and the peripheral nervous system. The central nervous system is coordinated through the brain and spinal cord, and the peripheral nervous system is through the autonomic and the somatic nervous system. And the somatic nervous system is further divided into the cranial nerves and the spinal nerves. We as dental surgeons usually will have to deal with the cranial nerves, that is the branches of cranial nerve, fifth the cranial nerve and the seventh cranial nerve, that is the trigeminal nerve and the facial nerve. We'll try to understand the structure of the neuron. The peripheral nerve is supplied through the blood vessels and the veins in its epineurium, and within the epineurium are the fascicles. These fascicles are covered with the perineurium, and individual of these peripheral nerve fibers are covered with the endoneurium. These nerve fibers are usually myelinated or non-myelinated, and there are these nodes of Ranvier through the Schwann cells, which help in the rapid conduction of the impulses from the central nervous system. Then we have the individual cell body, that is the cell, the support center for the nerve conduction, and it has got dendrites. These dendrites are the ones which receive message from the central nervous system, and through the axons, the neural impulses are galvanized or are conducted towards the terminal branches of the axon, and they give the instruction to the muscle, tendons, etc. Now, with this basic understanding of the, the nervous system, we'll try to understand what, why, and how do these nerve injuries occur and the further management. The nerve injuries occur because of the thermal insult, or it can occur because of the ischemia, which can lead to the damage of the myelin sheath, or it can lead to complete sectioning of the nerve. So the damage leads to a different kind of a outcome, whereas a complete sectioning of the nerve usually will have to be treated by a surgical procedure. These all various the injury to the nerve occur during the various dental surgical procedures or during the restorative procedures such as the root canal treatment or the periapical surgical procedures. As I told you, we can recount again. The reasons are the ischemia, compression, traction, laceration, burning, crush injury, avulsion, focal contusion, or rarely it can be idiopathic, and sometimes viral infection, metabolic, and neural disorders can also lead to the nerve injuries. The more of these injuries occur during the minor surgical procedures such as nerve blocks, periapical surgeries, root canal treatment material, incision and damage, and the third molar surgery. To understand each one of them, let's look at the nerve injuries which occur during the giving the various nerve blocks. The commonest one are when we are giving the inferior alveolar nerve. The inferior alveolar nerve can directly get injured by the needle, or it can occur similarly to that of the mental nerve or the infraorbital nerve when the infraorbital nerve is being blocked, or it can occur to the greater palatine nerve when the nerve when we are trying to block the greater palatine nerve. These are the the commonest areas where the nerve can get injured. The periapical surgeries include incision and drainage for the dentoalveolar abscess, periapical curettage, apicectomy, retrograde endodontic treatment, perforation repair, root resection, hemisection, exploration surgeries, and intentional replantation are all the areas wherein the damage to the periapical neurovascular bundle is quite possible. Or during root canal treatment, extruded root canal material or an inadvertent filling can also lead to the injury, or the silver cones which are used or were rather used earlier were also one of the reasons for the injury to the inferior alveolar nerve. And then there are the incision and drainage, the procedure when it is done either intraorally or extraorally. More often extraorally, the marginal mandibular nerve and the various other branches may get injured. Then the most commonest surgical procedure otherwise which is carried out in the oral cavity is the removal of the third molar tooth, that is the impacted third molar tooth. So the injury can occur here to the inferior alveolar nerve, or it might at times injure even the facial artery or the lingual nerve, are the various uh, structures which can get damaged. To understand the nerve injuries, these nerve injuries are classified by many researchers, Lundberg, Sunderland, and Seddon. Perhaps the Seddon's classification is the most easiest one to remember. That is neuroparaxia, when there is a transient nerve blockade. Axonotmesis, the lesion in continuity. Here, the nerve recovery can occur spontaneously. And the last one is neurotemesis, wherein there is a complete severance of the nerve, and the recovery here requires an intervention. To understand the similar things on the diagrammatically, what we can see over here are that uh, in a type 1 there is only myelin damage, type 2 there is axonal damage, in type 3 there is axon and the endoneurium which is damaged, and in class 4 axon, endoneurium and the perineurium are damaged, and in class 5 axon, endoneurium, perineurium and the epineurium are all damaged. There are three basic processes which happen when the nerve is injured. The one is Wallerian degeneration. Here, because of the Wallerian degeneration of the myelin, the process of damage occurs within 7 to 10 days, and the portion of the nerve is unexcitable electrically. The other one, when the injury is more severe, is the axonal degeneration. The distal degenerated nerve cannot be excited when it is electrically, and of course even in this, because of the basement membrane and the Schwann cells survive, spontaneous recovery can occur in axonal degeneration. The rate of recovery is usually at the rate about 1 millimeter per day. The last one is the demyelination. There is a segmental destruction of the myelin sheath occurs without the axonal damage, and here there is a complete conduction blockade which requires an intervention. The diagram represents the same thing, uh, how the nerve injury affects. The various symptoms of the nerve injury are numbness, weakness, pain, tingling, burning, twitching, or sometimes uh, paralysis of the affected region. Let's look at the various strategies which are available for us to prevent the nerve injury. The prevention is the best option. Of course, there are three things. One is the consent, second one the imaging. These are the two integral parts of the prevention of nerve injury. With our experience, we know that written informed consent is almost mandatory when we are taking up these various surgical procedures in dentistry. And prior intimation has to be done to the patient. An explanation of the possible associated risk with the procedure should be documented and taken signed by the patient. And of course, one should remember that we should have the various imaging done, that is the radiographs or the cone beam CT scan or other imaging modalities, whatever are done, should be available with the case file, so that there is a clear-cut documentation of uh, the possibilities of nerve injury. Earlier, when the more common things which were used for identification of the nerve position was the slop technique or the Clark's shift cone technique, which was very commonly used. But nowadays, the cone beam CT scan has completely replaced this traditional imaging methods, and cone beam CT scan gives the position of the nerve in relation to the root in all the three dimensions. So it is possible for us to show the same thing to the patient and explain the risk which is involved and take a written consent before we proceed with the surgical or the dental procedure. There are various investigations can also be done. One of the most important thing is the history. There might have been a prior injury to the nerve, so this can only be revealed in the history. And in case there is a history of nerve injury or possibility of nerve injury, prior motor function, movements, muscle atrophy, sensory functions need to be evaluated for the presence of a tunnel sign or static light touch, two-point discrimination, pinprick detection, thermal discrimination must be evaluated if there is a prior history of injury or when there is a high risk of injury to the uh, neurovascular bundle during the procedure. And perhaps local anesthetic nerve box can also be given prior for an evaluation. Uh, Nerve conduction studies can also be done, uh, and where necessary, an MRI can be taken for the purpose of documentation. Um, This is a two-point discrimination, uh, uh, point discrimination test to measure the post-operative neurosensory disorders, or brush directional stroke test can also be carried out to identify the injury in the post-operative period. TENS, transcutaneous electric nerve stimulation, can be used if and when necessary. Let's look at these are the various modalities which we use for documentation, and then now we come down to the management of these nerve injuries. The management of nerve injury is more dependent on the pharmacological management. These include the use of corticosteroids, non-steroidal anti-inflammatory drugs, certain central nervous system drugs, and last one are the nerve repair procedures. The corticosteroids have a very beneficial effect on the inflamed and the compressed nerve, specifically more so when we have the inferior alveolar nerve, which is within the bony canal, and then the nerve injury in association with the edema can cause more damage to the nerve, and the use of corticosteroids is the best modality to relieve the nerve and decompress it. Uh, so the corticosteroids, if they are used early in the treatment, can be very, very beneficial. They also relieve pain due to the modulation of the inflammatory process itself. The preferred drug is prednisolone, 1 milligram per kg per day, that is maximum of 80 milligrams for the first week, and then stepping it down to 10 milligrams over the following week is found to be very beneficial in the management of these peripheral nerve injuries. Non-steroidal anti-inflammatory drugs, when it is combined with a corticosteroid such as ibuprofen 800 milligrams divided into divided doses, can be prescribed for a duration of 2 to 3 weeks. which are found to be very beneficial in the management of nerve injuries. The topical systemic medications can be used for chronic painful conditions. The commonest ones are the antiepileptics such as carbamazepine, oxcarbamazepine, pregabalin, or the gabapentin. The nortriptyline can be used in the dosage of 25 milligrams OD, or the more common ones which are used are gabapentin 100 to 300 milligrams once to three times a day, or pregabalin 50 milligrams three times a day have shown beneficial effects, especially when there is abnormal pain sensation or bizarre sensations such as dysesthesia. These central nervous system drugs are shown to have a beneficial effect. In cases where there is a severe burning sensation, a lignocaine patch can be used, and then tramadol if the dysesthesia is very severe. 50 milligrams once or twice a day can be used to control the pain. Uh, to control the pain. Now, coming down to the surgical procedures, it would rather be very important as seen in this CBCT. The foreign body, which is more radio dense over here, it is feasibly one should remove it through the socket itself, and the removal of this foreign body will definitely aid in the removal of in the recovery of the nerve injury. The further other things what we have currently available is the endoscopically assisted root removal. If you see over here in this case, the root is going through the nerve, or it is the root is on the buccal side of the nerve with a small residual root on the lingual side, and then we use a 30-degree or 70-degree scope on the distal surface of the mandibular 7 as shown in this particular picture. The 30 or 70-degree the endoscope will help us to visualize better the socket, and also small instrumentation can be used to remove these roots, and the removal of these roots has definitely helped in the surgical procedure itself, wherein we can try to prevent the injury to the nerve bundle, as well as after removal of the root piece or the foreign body, it is possible for us to carefully debride the nerve as well, so that the recovery is much better. The last option are the microneurosurgical techniques. There are specific indications for this, that is observed nerve severance, total anesthesia beyond 3 months, or severe hypoesthesia without improvement beyond 4 months. The contraindications are central neuropathic pain, dysesthesia when it is not abolished by a local anesthetic nerve block. Then there are other complications or other reasons might be there. A medically compromised patient. The principles of microneurosurgery include proper visualization, magnification, good hemostasis, removal of pathological tissue, proper adaptation of the nerve fragments or the snared nerve ends together, and suturing them without tension. The different techniques which we use are primary nerve repair, nerve grafting, nerve transfer, nerve conduits, and nerve allografts. This is necessary just to have an information about what are the surgical procedures which the surgeons use to repair these nerves. Sharply transected nerves should be repaired immediately. Crushed avulse blast injuries. Initially, when we observe the nerve injury, we just track the nerve ends with a silk suture and leave it alone. And subsequently, we wait for a duration of 3 weeks. And after 3 weeks, we re-explore the area, remove the granulation tissue, identify the nerve ends, and depends upon whether the nerve graft is necessary, conduits are necessary, are adopted as per the situation, and the nerves are repaired. Primary repair, of course, after decompression, internally the nerve is cleared, that is neurolysis, stumps are mobilized, and without any gap, they should be closed together with the sutures, that is the neurography. Neurography can be done by different approaches. There is the epineural approach when there is a more damage to the nerve and the surrounding tissue. Epineural approach seems to be the uh, possible way to try to get an adaptation of the severe nerve ends. The fascicular repair is much better, wherein the individual fascicles are sutured together and the internal topography of the nerve can be restored here, and intraoperatively it is possible to stimulate the nerve and check for the response as well. Group fascicular repair is another one wherein groups of these fascicles are sutured together. Again, individual fascicular suturing is much better as compared to the group fascicular repair. Nerve grafts are interposed between the nerve stumps to eliminate the tension and facilitate healing uh, for the neuropathy. And the ideal nerve grafts they should be easily removed. There should not be much fat, and the cross-sectional area of the nerve should be equivalent to the recipient area, and they should be of sufficient length. The sural nerve graft is one of the nerve which is uh, usually very useful in the maxillofacial region, and nerve allografts are also available such as Axogen. They can be used during the nerve repair, or the conduits are available. This is the new technique for bridging the nerve gaps. Usually gaps around 1 to 3 centimeter of the nerve gap can be repaired with this. This will help to direct the axons from the proximal to the distal stump. Then varied conduits are available. These can be veins or pseudo sheets, and bioresorbable tubes are used as conduits for the repair of the nerve. The results of nerve repair depend upon the preoperative conditions such as the time of injury, infection, and during the operative time, the nerve affected, tension, and the type of suture materials which are used. Post-operatively, immobilization and prevention of infection are paramount important. And also the post-operative synesthesia can be minimized by the learning procedure, or that is a readaptation of the readaptation of the sensation of the affected nerve can be minimized by the learning process. So the re-education begins by perceiving of any sensation, and the use of alternate massages or stimulation of the contralateral normal side and the affected side simultaneously using fingers, cotton swabs, bobby pins, etc. repeated several times a daily and continued for months together will help in achieving the sensation back to the normal. So this one shows a grade and the recovery of sensibility. Um, Now, in simplified terms, so when the nerve repair is done, usually what we come across is the anesthesia in the initial 3 to 4 months period of time, and then there is paresthesia or dysesthesia for about 4 to 8 months period of time, and hypoesthesia can continue up to an year, and subsequent to an year, there is a complete recovery of the sensation. All this is dependent upon the recovery dependent upon the various conditions which I outlined and the post-operative rehabilitation what is carried out for the patients. So this is how the nerve injuries repairs are carried out. To make a specific point about the inferior alveolar nerve, if it is damaged in the body region, then the procedure becomes even more difficult to repair because the lateral cortex of the mandible will have to be removed, and then the neurovascular bundle has to be accessed to repair it. Whereas the other commonest injured nerve is a lingual nerve, and the lingual nerve is it's possible to visualize it a little better if the mouth opening is good, and in those cases when there is a complete severance, the lingual nerve micro neurosurgery is carried out for repair of the lingual nerve. Well, having understood all these things, one of the common things I see among the general dental practitioners is to use the neurobion, that is vitamin B2, B6, and B12 for any nerve injury. Well, I think one can understand that that doesn't really stand much chance for the recovery of nerve injury, and it is important to understand the process of nerve injury, the preventive mechanisms, the objective identification, and the effective treatment for nerve injuries will help in better recovery of the injured peripheral nerves in our general dental practice. Thank you very much.
Thank you, sir, for this very relevant and practical lecture on the management of nerve injuries in general dental practice. IODCPC 25 is pleased to present you with the certificate of appreciation.